Speaking against the use of anti-VEGF therapy for nonproliferative diabetic retinopathy is Yannick Lederman. Yannick, tough road to hoe.
Indeed. Thank you. I've served as a consultant for Genentech and Regeneron, although that status may be in question after this debate. So the first most important question that we have to frame in this debate is that of endpoints. My esteemed colleague, Dr. Doe, and Dr. Gross before have talked about progression of retinopathy. And while this looks impressive in anecdotal individual photos and cases, the problem with that is nearly all of our studies in diabetic eye disease look at visual acuity, either improvement in acuity or prevention of loss. In fact, we can reach back to the DRS, which was a powerful study that the NEI really holds up in the entire house of medicine. And what made it so powerful? This is a very elegant figure from that study. It was what risk factors for severe visual loss and diabetic retinopathy were present in this study, and we use this to this day to guide our treatment. So note the column on the right. Everything was correlated to preventing loss of vision. And interestingly, many of us haven't looked at this study in some time. Even in proliferative diabetic retinopathy, without those high-risk factors that put you at severe risk for loss, the incidence in 2 years of severe loss of vision was less than 4%. So what are the data for anti-VEGF in NPDR? Well, we've discussed RIDE and RISE, and those included a post-hoc analysis of DR in patients already being treated for DME, so that doesn't really apply here fully. Panorama did look specifically at moderately severe and severe NPDR without center-involving DME. But again, the issue in interpreting those studies were that they looked at retinopathy, at progression to PDR, and anterior segment neovascularization, and progression to DME, but not in prevention of loss of vision in NPDR. Endurance is an interesting study to investigate. It was a follow-up to the 3-year VISTA study. There we do have some data on vision, and they show that there was no difference in change in vision between patients who were receiving anti-VEGF treatments and those who did not during endurance. And it's particularly instructive to note that during the 2-year endurance extension study, 10% of eyes progressed from NPDR to PDR for the first time. And this was in the context of a rigorous prospective clinical trial. These patients were not lost to follow-up. 1/3 of those patients lost 15 more of those letters. So the intervals between visits to investigator discretion within the protocol were extended up to a maximum of between 16 and 20 weeks. Nonetheless, if we look at this Kaplan-Meier survival curve of time to first PDR progression, this is not something that looks very reassuring to me in terms of anti-VEGF in even preventing PDR in real-world circumstances. Our final question, is there a risk of harm? So let's do a number needed to harm analysis. Dr. Doe did a number needed to treat analysis. Let's assume an endophthalmitis rate of 1 in 2,500 injections, which is fairly middle of the road. And we'll assume only 2 intravitreal injections per year, which is really, I think, pretty modest in terms of treating retinopathy. And let's look at a 5-year interval, so 10 injections altogether. So performing this fairly simple calculation, any of us could do this, that tells us that there's a 0.4% chance that at least 1 incidence of endophthalmitis will occur over the course of 10 injections. This is something that all of you hopefully at some point have seen or considered. We have to assume a 0% incidence of endophthalmitis in the untreated group because our gold standard for NPDR is observation, right? And a 0.4% incidence in the treatment group of 5 years. The number needed to harm is 250 eyes. Put another way, on average, for every 250 patients we see, even if we're only talking about severe NPDR in our clinics, for every 250 eyes or 125 patients that we inject, 1 additional eye will develop endophthalmitis. That is not trivial. Ultimately, I am a strong proponent of anti-VEGF. I certainly use it in DME. I use it selectively in DR. But in terms of its broad use in NPDR, there are significant questions about prevention of vision loss. There are even questions regarding the real-world efficacy in preventing progression to PDR. And certainly we have to take into account the risk-benefit analysis. Ultimately, all of you are charged with the following question, and that's whether non-proliferative diabetic retinopathy should be treated routinely with anti-VEGF. And I think the answer to that question is hiding in plain sight. DRCR-Net Protocol W, and this is taken directly from the neiclinicaltrials.gov website, states, quote, "It is unknown whether or not anti-VEGF treatment in severe NPDR would result in favorable visual acuity outcomes." To be determined, but that certainly does not help us to say definitively that anti-VEGF should be used in NPDR. I think the answer is no. Thank you.